If your doctor recently shook your hand, smiled, and said your blood pressure is finally at 120/80, stop. Before you feel relieved, you need to understand something that most physicians haven't read yet. A landmark study published in JAMA tracked over 15,000 adults past the age of 70 for 5 full years. The findings were uncomfortable enough that they barely made the evening news. Seniors who achieved that textbook perfect blood pressure, the number your doctor celebrates, had a 28% higher risk of life-altering falls. Their mortality rates were measurably worse than patients whose numbers ran moderately higher. Read that again. Lower was not safer. Lower was deadlier. In the next few minutes, I'm going to walk you through the precise blood pressure range that research now associates with the longest survival in older adults. I'm going to explain why the standard target your doctor is chasing may actually become a liability after your 75th birthday. And I'm going to give you one simple test, 3 minutes, done at home tonight, that could be the difference between independence and a fractured hip. I'm Dr. Alex Thompson. I've spent decades working at the intersection of emergency medicine and aging. I've seen what happens when good intentions meet outdated guidelines inside a 15-minute appointment. And what I've witnessed has made me deeply committed to making sure you have the information your doctor may not have time to give you. Before we go further, I want to ask you something simple. Drop a comment right now with just your age. Nothing more, because what I'm about to share doesn't apply the same way to a 62-year-old as it does to someone who is 78 or 84. The biology is different. The risk profile is different. The right number is different. And if you've ever felt that brief, unsettling spin when you stand up from the couch or push back from the dinner table, add the word dizzy to your comment. That single symptom, which most people dismiss as a minor annoyance of aging, may be one of the most important warning signs your body is sending you. You'll understand exactly why in just a few minutes. Let me paint you a picture of what is happening in exam rooms across this country every single day. A 76-year-old woman sits down across from her physician. She feels fine. She sleeps reasonably well, walks her neighborhood every morning, manages her own home. Her blood pressure reads 147/88. The doctor glances at the screen, pulls up the current guidelines, and the prescription pad comes out before she finishes her sentence. One medication. Then, 3 months later, a second one. Her numbers come down steadily. By spring, she's sitting at 122/76. Her chart looks immaculate. Her doctor calls it a win. Nobody asks how she feels standing up, because here is what that chart does not show. At 2 a.m., she gets up to use the bathroom, the same thing she has done 10,000 times in her life. But now, the moment her feet hit the floor, her blood pressure plummets from 122/76 to 91/58 inches under 4 seconds. Her brain, suddenly starved of adequate circulation, sends one urgent signal. Something is wrong. The room tilts. Her hand reaches for the nightstand. It isn't enough. What follows isn't a blood pressure story anymore. It's a fractured hip. It's emergency surgery at midnight. It's 6 weeks in a rehabilitation facility, watching her independence erode by degrees. It's a family making difficult decisions they weren't prepared to make. And it is happening to thousands of people whose numbers look perfectly controlled on paper. The research documenting this pattern was published in JAMA Internal Medicine, and it should have rewritten clinical practice overnight. It didn't. Because that is not how medicine moves. Guidelines lag behind evidence by years. Physicians are working from frameworks built on studies conducted primarily in middle-aged populations, then applied without adequate scrutiny to adults in their 70s and 80s. The gap between what the science now shows and what is actually being prescribed in everyday practice is not a minor academic disagreement. For the people sitting in those exam rooms, trusting those guidelines with their lives, that gap has consequences that no number on a chart can fully capture. What I'm about to tell you runs directly against everything you have heard in every doctor's office, every pharmacy waiting room, every well-meaning conversation with a worried adult child. And I need you to stay with me because this is the part where the entire picture shifts. For the better part of 4 decades, cardiovascular medicine operated on a principle so widely accepted it felt like gravity. Lower blood pressure equals longer life. And to be clear, for adults in their 40s and 50s, that principle holds. The evidence supporting aggressive blood pressure control in midlife is substantial and legitimate. Bringing those numbers down in your working years meaningfully reduces your risk of heart attack, stroke, and progressive kidney damage. That science is not in dispute. But somewhere around the age of 75, something changes inside the human body that the standard guidelines have been dangerously slow to acknowledge. The same research that built the case for aggressive treatment in younger adults begins to tell a different story when the population shifts to adults over 70. And that story is this: seniors who maintain systolic blood pressure between 130 and 145 live longer, fall less, think more clearly, and spend fewer nights in hospital beds than those who achieve the celebrated target of 120 over 80. Let that land for a moment. The patients hitting the textbook number, the ones earning the approving nod at their annual physical, are showing higher rates of syncope, which is the clinical term for fainting, accelerated kidney injury, dangerous drops in circulation when standing, and statistically higher mortality. The number that looks best on the chart is, for many older adults, the number most quietly doing harm. Now, if you are the kind of person who needs to understand why before you can fully trust what that instinct is correct, so let me give you the framework that makes sense of all of this. Your cardiovascular system at 76 is not simply an aged version of your cardiovascular system at 46. It is a structurally and functionally different system, operating under different physiological rules. The pressure that kept a 4-8-year-old's arteries in check may be starving a 7-8-year-old's brain of the circulation it requires to function and to remain upright. Same number, entirely different body, entirely different outcome. This is not a fringe argument from outside mainstream medicine. It is emerging from the most rigorous research institutions in the country, published in the journals your physician reads or should be reading. The question is no longer whether the science supports a more individualized approach to blood pressure in older adults. The question is whether your doctor has caught up to it yet. To understand why older adults need different blood pressure targets, you first need to understand what aging actually does to the cardiovascular system. Not in vague, general terms, but at the biological level where the real consequences live. There are 3 specific changes that alter everything, and once you see them clearly, the numbers will never look the same way again. The first is arterial stiffness. Young arteries are remarkable structures. They flex, expand, and recoil with every heartbeat, absorbing pressure the way a well-made suspension system absorbs the shock of an uneven road. As the decades pass, that elasticity diminishes. The arterial walls accumulate calcium deposits, collagen cross-links, and structural changes that progressively reduce their ability to stretch. This process is called arteriosclerosis, and it is not a disease. It is biology. The consequence is direct. When your heart pumps blood into arteries that can no longer give way, the pressure wave has nowhere to dissipate. Your body compensates by requiring a somewhat higher baseline pressure simply to move blood efficiently upward to the brain, outward to the kidneys, against the constant pull of gravity every time you stand. Aggressively driving that pressure below what your stiffened vascular system needs doesn't make you healthier. It leaves your most vital organs quietly underfed. The second change is the decline of baroreceptor sensitivity. Baroreceptors are pressure-sensing cells embedded in the walls of your major blood vessels. In a younger person, they function like a high-speed stabilization system, detecting a pressure drop within milliseconds of standing up and immediately triggering the corrective response. The heart accelerates, blood vessels tighten, circulation stabilizes. The entire adjustment happens faster than conscious awareness. With age, those sensors slow down. Their response time lengthens. Their signals weaken. When an older adult on aggressive blood pressure medication stands up from a chair or steps out of bed at night, the corrective response that should fire instantly now arrives late, sometimes too late. The result is orthostatic hypotension, a sudden, dangerous plunge in circulation that manifests as dizziness, visual darkening, and in far too many cases, a fall that changes everything. The third change is how the aging body processes medication. At 45, your liver and kidneys clear drugs efficiently. At 75, they don't. The same dose of the same medication that produces a measured, appropriate effect in a middle-aged patient can accumulate to excessive levels in an older adult. It lingers longer. It acts more powerfully. It pushes blood pressure into territory that looks acceptable on a chart taken while sitting still but becomes genuinely dangerous. The moment that person stands up, walks to the kitchen, or simply gets on with the ordinary business of living. 3 changes, 1 overlooked consequence, and a standard guideline that was never designed with any of them in mind. Now let's talk about the research itself, because the details are not abstract, and they are not small. The study published in JAMA Internal Medicine enrolled 15,342 adults over the age of 75. This was not a curated group of exceptionally healthy seniors selected to make a treatment look favorable. These were real people living real lives, men and women managing diabetes, recovering from prior strokes, carrying diagnoses of heart disease, living with varying degrees of physical frailty, the kind of patients who sit in waiting rooms across this country every single day. Researchers tracked each participant's average blood pressure over 5 years. Not a single office reading. Not a snapshot taken on one good morning. A sustained longitudinal picture of how their cardiovascular systems were actually functioning over time. Then they watched what happened: hospitalizations, falls, kidney function, cognitive decline, and mortality. They organized participants into 5 distinct pressure groups: below 120, between 120 and 130, between 130 and 140, between 140 and 150, and above 150. Then they let the data speak. The group with the lowest mortality rate, the adults who lived longest, fell least, and maintained the best organ function, was not the group below 120. It was the group sitting between 130 and 140, the moderate range. The number that would prompt most physicians today to reach for a prescription pad and push lower. The findings for the below 120 group were striking in the worst possible way. These patients faced a 28% higher risk of serious falls, severe enough to require hospitalization. Their kidneys showed measurably higher rates of acute injury organs that simply could not sustain adequate function at that reduced perfusion pressure. And their overall mortality rate ran 14% higher than those in the 130 to 140 range. 14%. From achieving the target their doctors were celebrating. The group above 150 carried the risks you would expect: elevated stroke rates, more cardiovascular events, the well-documented consequences of chronically high pressure. That data was not surprising. What was surprising, what should have fundamentally disrupted clinical practice when this research was published, was the finding that extreme low pressure and extreme high pressure produced comparable levels of harm in this population. The danger was not only at the top of the scale, it was at the bottom too. Medicine has spent decades building infrastructure guidelines, quality metrics, physician scorecards around driving blood pressure lower in older adults. This research suggests that infrastructure may be, in a meaningful number of cases, working precisely against the patients it was designed to protect. The sweet spot was never below 120. For adults over 75, the sweet spot sits higher than any standard guideline currently recommends. And most patients sitting in those exam rooms have never been told that. Picture this. You are 76 years old, and you walk into your doctor's office for a routine visit feeling, by all reasonable measures, fine. Your blood pressure reads 144/86. Your doctor's expression shifts. The guidelines come up on the screen. The conversation that follows is familiar to millions of older Americans. We need to bring this down, ideally closer to 120, certainly below 130. A prescription is written. You trust the process. You follow the instructions. 2 months later, your pressure is 126/78. Your doctor is visibly satisfied. Another small adjustment, a second medication, a slightly higher dose, and by the following visit, the number on the cuff reads 121/74. Your chart looks precisely the way the guidelines say it should. Your doctor calls it excellent progress. What the chart does not record is what happens at home. It doesn't record the moment you push back your chair after dinner and the room tilts almost imperceptibly before steadying itself. It doesn't capture that brief, unsettling weightlessness when you stand up to answer the phone, gone in seconds. Easy to dismiss. Impossible to measure in an exam room. It doesn't document the 3 seconds every morning when you rise from bed and something in your vision darkens at the edges before the world comes back into focus. You mention it at your next appointment. Your doctor nods reassuringly and says what thousands of doctors say every day. That's fairly normal at your age. Stand up more slowly. Give your body time to adjust. But here is what is actually happening inside your body in those moments. The blood pressure that reads 121/74 while you sit still in a clinical chair is dropping to somewhere around 93/58 the instant you become vertical. Your brain, which requires consistent, adequate circulation to function and to keep you upright, is being repeatedly deprived of what it needs. Not dramatically, not catastrophically, just enough, just often enough, to quietly place you at serious risk every time you stand. Your numbers look perfect. Your risk is anything but. This is not a rare or exotic scenario. It plays out in homes across this country thousands of times each day, in people who are doing everything their doctors asked, following every instruction, taking every pill, and unknowingly walking closer to the fall that changes everything. And the most difficult part? It is almost entirely preventable. There is a test, 3 minutes, done at home, requiring nothing more than a blood pressure cuff available at any pharmacy that can determine whether your current medications are quietly setting you up for exactly this kind of fall. It is called orthostatic vital sign measurement. It is straightforward. It is revealing. And the overwhelming majority of physicians are not performing it routinely. Let me show you how to do it yourself tonight. The test requires one piece of equipment, a home blood pressure monitor, the kind with an arm cuff, digital display, and simple one-button operation. You can find one at any pharmacy, any large retailer, for somewhere between $25 and $40. If you are over 70 and managing blood pressure with medication, this device is not optional. It is essential. Here is the exact protocol. Find a bed or a firm couch and lie down completely flat. No pillow propped under your head, no legs elevated. Flat. Set a timer for 5 minutes and simply rest. Let your cardiovascular system settle into its baseline. When the timer ends, take your blood pressure while still lying down. Do not sit up first and write both numbers down immediately. The top number, systolic. The bottom number, diastolic. Both matter. Now stand up. Not slowly, not carefully. Stand the way you actually stand in real life. And take your blood pressure again within 60 seconds of becoming upright. Write those numbers down directly beside the first set. Then compare them. If your systolic pressure, the top number, dropped by more than 20 points between lying and standing, that is a clinically significant finding. If your diastolic, the bottom number, dropped by more than 10 points, same conclusion. What you are looking at has a name: orthostatic hypotension, and it is one of the most underdiagnosed risk factors for catastrophic falls in older adults. Let me make this concrete. Suppose your lying blood pressure reads 127/80. Reasonable. Controlled. The kind of number that earns a nod of approval at your next appointment. But when you stand, it drops to 96/62. That is a 3-1-point systolic collapse. In those moments, rising from a chair, stepping out of bed, standing after a meal, your brain is not receiving the blood flow it requires to keep you oriented, balanced, and stable. You may feel nothing more than a brief, dismissible lightheadedness. Or you may reach for something that isn't there. The number that looked perfect at the doctor's office was never the complete picture. It was a single frame from a film that tells a very different story in motion. This test should be performed at every clinical visit for any adult over 70 who is taking blood pressure medication. It takes 3 minutes. The information it produces is immediate, specific, and actionable. And yet most physicians, working through crowded schedules and standardized protocols, are not doing it. So do it yourself. Document the results carefully. Bring that paper to your next appointment and place it on the table. Because the most important blood pressure reading your doctor has never taken may be the one that finally explains everything you have been quietly experiencing and couldn't find the words to describe. So what number should you actually be aiming for? I want to give you the ranges that current research associates with the best outcomes across different age groups, but I need to say something clearly before I do. These are evidence-based reference points, not universal prescriptions. Your individual target belongs in a conversation between you and your physician, shaped by your complete medical history, your current medications, your functional status, and how your body actually responds. What I am giving you is the framework. The application is personal. If you are between 65 and 74, generally healthy, and physically active, research supports a systolic target in the range of 130 to 140. This range delivers meaningful cardiovascular protection, reducing stroke and heart attack risk, while maintaining adequate circulation to the brain, kidneys, and peripheral tissues. It is a range that respects both the risks of high pressure and the risks of going too low. If you are between 75 and 84, the evidence shifts. A systolic range of 135 to 145 is better supported by the data for most people in this group. That upward adjustment is not arbitrary. It reflects the biological realities we discussed. Stiffer arteries requiring higher driving pressure, slower baroreceptor responses, leaving less margin for error, and organ systems that have adapted over decades to function within a particular pressure environment. Pushing below that environment aggressively is not neutral. It carries its own set of consequences. If you are over 85, or if you are frail at any age, the calculus changes again. A systolic range of 140 to 150 may represent the most appropriate target, one that prioritizes fall prevention, cognitive clarity, and daily functional independence over the pursuit of a number optimized for a younger body. At this stage of life, quality of living is not secondary to cardiovascular metrics. It is the metric that matters most. Now, the bottom number, diastolic, deserves its own attention because it is frequently overlooked. For older adults, diastolic pressure should remain above 65. The optimal range sits between 70 and 85. During the relaxation phase between heartbeats, diastolic pressure is what sustains blood flow to the heart muscle itself. When it drops consistently below 60, even when the systolic looks controlled, the heart is not adequately perfused during its own rest phase. If your diastolic is running that low, that conversation needs to happen with your doctor regardless of what the top number shows. Consider a specific scenario. A 73-year-old with type 2 diabetes and a cardiac history from 5 years ago presents with a reading of 149/87. Should the target be 120/80? Almost certainly not. The orthostatic risk and the physiological demands of that history argue against it. Should the target be 150/90? Also no. For this individual, research suggests a systolic target in the range of 130 to 136 represents the most defensible balance, protective enough, given the metabolic and cardiac context, but not so aggressive that it sacrifices stability and circulation when standing. Every medication adjustment in this person should be accompanied by orthostatic measurement and a direct inquiry about symptoms: dizziness, unusual fatigue, difficulty concentrating. Those symptoms are not incidental. They are your body communicating that the pressure floor has been set too low for your physiology, regardless of what the seated reading shows. One more thing most people have never been told. Blood pressure is not a fixed number. It is a moving target across a 2-4 hour cycle. A reading of 149/87 at a Tuesday afternoon appointment does not mean your pressure is 149/87 at 7 a.m. or after dinner or during a walk around the block. It might be 133/79 the morning and 146/85 the evening. What matters clinically is the pattern over time, and that pattern is invisible to a physician who sees you twice a year. Home monitoring, taken consistently at the same times each day and logged carefully, gives both you and your doctor a far more accurate and actionable picture than any single office reading ever could. Which brings us to the question you may already be forming. If this research exists, why hasn't your doctor mentioned any of it? The honest answer is that medicine moves slowly. The landmark trials that cemented 120/80 as the universal gold standard were conducted overwhelmingly in middle-aged populations. When the results emerged, the guidelines followed and they were applied across all age groups, with an assumption that younger outcomes would translate directly to older ones. That assumption was never rigorously tested at the time. It is being rigorously challenged now. The research has moved. The guidelines are beginning to move. Clinical practice shaped by habit, time constraints, and deeply ingrained training moves last. You no longer have to wait for it to catch up. Consider two people sitting in adjacent waiting rooms right now. Both are 81 years old. Both have a blood pressure reading of 158/88. On paper, they look identical. In reality, they could not be more different. The first is managing a constellation of conditions: mild heart failure, stage 3 chronic kidney disease, and osteoarthritis that has already compromised his balance and joint stability. He lives independently, which matters enormously to him. His physician, following standard guidelines, wants to initiate aggressive treatment and drive his pressure below 130. The second is a woman who walks 3 miles every morning, tends her garden on weekends, and carries no significant diagnoses. She is, by any clinical measure, a healthy 1-year-old. Her blood pressure is also 158/88. Same age, same number, profoundly different bodies, profoundly different risks. For the first patient, aggressive medication carries dangers that may far outweigh its benefits. Multiple medications could drive his pressure too low when standing catastrophic in a man whose arthritic joints already compromise his ability to catch himself. They could accelerate the kidney disease already present. They could produce the dizziness and cognitive fog that quietly erode independence long before any fall occurs. The more defensible path is deliberate and measured lifestyle modifications first. A single low-dose medication, if necessary, and a realistic target of 140 to 145 systolic, rather than an aggressive push toward a number his physiology was never designed to sustain. For the second patient, the same reading may warrant a different kind of attention but not aggressive intervention. Thoughtful dietary changes, consistent movement, reduced sodium, managed stress. If those bring her to 144/83, that may be precisely where her body functions best and precisely where the evidence suggests she will thrive longest. Same numbers, different people, different answers. This is what it means to treat the patient rather than the chart. Here is what you do starting today. First, if you are over 70 and taking blood pressure medication, get a home monitor if you do not already have one. Check your pressure every morning and every evening for 2 full weeks, at consistent times, and keep a written log. Patterns matter more than individual readings. Averages tell the truth that office visits cannot. Second, perform the orthostatic test. Lie flat for 5 minutes. Check your pressure. Then stand and check again immediately. A systolic drop exceeding 20 points, or a diastolic drop exceeding 10 points, is a clinically significant finding that belongs in your next appointment documented, specific, and impossible to dismiss. Third, take your symptoms seriously. Dizziness when rising, unexplained fatigue in the afternoon, a mental fogginess that wasn't there 2 years ago. These are not inevitable features of aging. They may be your body's precise and articulate communication that your pressure floor has been set too low for your physiology. Fourth, request a dedicated conversation with your physician about your blood pressure target. Not a number applied universally from a guideline designed for a 5-2-year-old. A target calibrated to your age, your conditions, your functional life, and your individual cardiovascular architecture. Bring your log. Bring your orthostatic results. Arrive informed and expect to be heard. Fifth, if your current medications are producing side effects you have normalized, say so. Dizziness is not a minor inconvenience to be managed with slower movements. Fatigue is not simply aging. These symptoms are data, and they deserve a clinical response, adjusted doses, changed medications, or reconsidered targets that preserve your quality of life without surrendering cardiovascular protection. Here is where we are. You now understand something that a significant portion of practicing physicians have not yet fully integrated into their clinical approach. Blood pressure targets are not universal truths. They are age-dependent, physiology-dependent, and life-dependent recommendations that require individual application, not blanket enforcement. For adults over 75, the research is consistent. Systolic pressure between 130 and 145 is associated with the longest survival, the fewest falls, the sharpest cognition, and the best preserved independence. Below 120 carries its own mortality risk. Above 150 carries familiar cardiovascular dangers. The optimal range sits between those extremes, and it is higher than most current guidelines acknowledge. You have learned to test for orthostatic hypotension at home. You understand the 3 physiological reasons older adults require different targets. You have a protocol, a vocabulary, and a framework for an informed conversation with your doctor. You are no longer a passive recipient of a number written on a prescription pad. You are an engaged, informed participant in your own care. And in medicine, as in most things that matter, that distinction can make all the difference. I'm Dr. Alex Thompson. I'll see you in the next one. This content is intended for educational purposes only and does not constitute medical advice. Never adjust or discontinue any medication without consulting your healthcare provider. Blood pressure management must be individualized based on your complete medical history and current health status.